Hello, sir.
Sir, yeah, tell me, Ram.
Sir,
Yeah, tell
sir,
me.
can you take the pitfalls in NCS, sir?
Yeah, no problem. Shall you do it next week?
Sure, sir. Sure, sir.
Yeah, today.
Oh, thank you,
I,
sir.
I will add some more cases and then bring it next week. Okay.
Oh, okay, sir. Okay, sir. Thank you
Right.
so much, sir.
No, no, Rashida. Right. Okay, now we'll start. Purva, shall I start? Purva. Okay, we'll start. Now, I will start with the first case, a short case first. This case was actually, in fact, meant for last week's presentation. Since I could not get time on that day, I am presenting this today. After that, I'll go for the long case. Can you see my slides?
Yes, sir.
Yeah, right. Now, this is a story of a 26-year-old female. She had a brain insult at the age of 3 years and left with left hemiparesis. Over the subsequent years, she noticed tremulous movement of her left hand, causing problem in doing activities with the left hand. This is the involuntary movement she had. ഇങ്ങനെ കൊണ്ടോ ഇങ്ങനെ പിടി ഞാൻ നേരത്തെ പിടിച്ചു വരാൻ പിടിക്കില്ല എനിക്ക് അറിയാൻ വേണ്ടി ഇത് കുറയുന്നു എന്ന് അറിയാൻ വേണ്ടിയിട്ട് അതിന് തൊട്ടേ തൊട്ടോണ്ടിരുന്നേ പിടിക്കണ്ട നീക്ക് അറിയണേ ഇനി എൻ്റെ വിരലിൽ തൊട്ടേ വിരലിൽ തൊട്ട് മൂക്കി തൊട്ടേ ഇനി വിരലിൽ തൊട്ടോണ്ടിരുന്നേ തൊട്ടോണ്ടിരിക്കും മോളെ. Okay, I'll play the video once again. The case is brought only for the involuntary movement. നേരത്തെ പിടിച്ചു വരാൻ പിടിക്കില്ല എനിക്ക് അറിയാൻ വേണ്ടി ഇത് കുറയുന്നു എന്ന് അറിയാൻ വേണ്ടിയിട്ട് അതിന് തൊട്ടേ തൊട്ടോണ്ടിരുന്നേ പിടിക്കണ്ട നീക്ക് അറിയണേ ഇനി എൻ്റെ വിരലിൽ തൊട്ടേ വിരലിൽ തൊട്ട് മൂക്കി തൊട്ടേ ഇനി വിരലിൽ തൊട്ടോണ്ടിരുന്നേ തൊട്ടോണ്ടിരിക്കും മോളെ. Okay, what do you think this involuntary movement is?
It looks like a distal jerky type of a movement, which with some sort of a postural aggravation or aggravation with action, with some sort of an action myoclonus while attempting to touch the nose, with increase of incoordination, but the incoordination is not fitting with classical intention tremor. So I would keep a distal predominant postural incoordination with probably an action myoclonus type of unilateral phenomena, sir.
Okay, you're right, but the thing is that actually he has
Also
got
a chorea component to it, some sort of a chorea, a terminal chorea.
Actually, here, what the predominant involuntary movement is tremor, okay? And the tremor has got a postural tremor as well as a profound intention component. Intention component is so severe that she cannot even keep the hand on the nose. Normally, intention tremor should stop when the hand reaches the target. Since she has got a postural component also, it is continued to occur even after reaching the target. So it's got a postural plus a gross intention tremor, and as you said correctly, she has also got incoordination. Okay, and in addition, it's got abnormal posturing on the left hand. As you said, he has got a dystonic posturing.
Dystonic myoclonus, sir.
But it's confined only to one hand. Only to one hand. This is a sequelae of old left hemipariesis which we had earlier. It has got a postural tremor and the gross. When you try to touch the finger, it becomes more. See, it's become more on touching the finger. But continue to occur even if touching. See the degree of intention tremor she has got. See that thing. And obviously, she's hand is in the wrist is the flexed position, then fingers are hyperextended, a dystonic posture. So this tremor is classical of what this is called the rubral tremor. Rubral tremor is one which has got a rest, postural as well as intention component. intentional component is more than the postural component. Postural component is more than the rest component. And so then dystonic position in the left hand and left hand ataxia. So what could be the site of lesion in this patient? The patient might have had
The cerebellar outflow tract, the long
correct,
tremorogenic loop. Yeah.
right. Yeah, right. It's a outflow tract, maybe in the red nucleus or its connection with the thalamus, anywhere it is possible. And this is the MRA of the patient. Now, we do not know what the situation which has happened earlier. Now, what you observe is, you look at the thalamus on the right side. It's so much atrophied on the posterior part, so also the midbrain is also atrophied on the right side. See, look at also the atrophy of the midbrain, atrophy of the posterior part of the thalamus. Now, question number one, why should this has happened at the age of 3 years, but why do the involuntary movement progressively develop later on? It was not there at the beginning.
Sir, is there any GRD film available? Is there a vascular malformation there, sir?
Nothing there. No vascular formation, anything. If it was, it would have been seen here also.
Sir, if we consider the short and the long tremorogenic loops, it passes from the dentate, then goes to the red nucleus, and then to the rubrothalamic part, which progresses into the striatal part or the part associated with extrapyramidal. So, if there is a rubrothalamic problem, a functional connectivity disorder, we might get a rubral tremor, even in the absence of any MRI abnormality. We sometimes have rubral tremors, sir, but
No,
it is
no.
often bilateral, not unilateral.
Yeah, no, that's not my question. My question was her insult happened long back at the age of 3. But this movement developed later on.
HOD, sir.
Yeah. Why it occur?
Sir,
HOD.
because there can be central tegmental tract problem
No.
downstream. Yeah.
No, this is not. This is a situation for all involuntary movements, be it released in the caudate or putamen or in the thalamus or red nucleus. The insult may occur now. Subsequently, only later on they develop the involuntary movement. The involuntary movement even can also progress. Even in midbrain, classical midbrain infarct, the involuntary movement can develop later on, just like you said, central tegmental tract lesion developing later on. This is peculiar for involuntary movement. So the late development of involvement does not mean that the lesion is progressing. It may be a sequelae of the acute static insult itself. So it's well described in literature. This is that I've seen many cases like that.
So this is common in cerebral palsy, sir. And after stroke.
No, she has had a stroke a stroke or encephalitis at that time, had a damage to this particular part of the brain, and that is left hemiplegia at that time. The later hemiplegia is improved, but the involuntary movement appeared later on. This video is after treatment. Look at the treatment now. It is still there, but much less than before. It is still there, but compared to the previous one, it is less. She is happy that she says 50% better. See, it is much better. So what medication was given to her?
The clonazepam,
Levodopa.
pacitane, and
Levodopas.
valproate maybe.
Rubral tremor, some of them do.
Levodopas.
Some of them do respond to rubral tremor, respond to levodopa, but this patient did not respond to levodopa at all. Not to clonazepam.
Primidone, sir.
Revocon will not work in this kind of tremor. And one drug which I know very fake. Primidone is used for benign essential tremor, not for this rubral tremor.
Zonisamide.
Zonisamide. No, zonisamide. No, this zonisamide. I know. I think very good drug which you should always keep in tremor. All dystonic type of tremors, I find it very useful. I got 2 patients with dystonic myoclonus. The one in the hereditary myoclonus, the lightning jerk and myoclonus. They respond very well to zonisamide. I had one patient who did not respond to pacitane but responded to zonisamide. So this, and again, nuchal tremor also, they respond very well. Last time I showed one BET presenting with dystonia tremor on the neck. He responded very well to sonisamide. I think this drug you should try in this case. I never thought she would improve.
What
Yeah.
dose, sir? What dose?
No, I started with 50 milligram BD, increased to 100 milligram BD.
Sir, we have
Okay.
even found that if the patient cannot afford zonisamide, high doses of lacosamide does the same thing, sir.
Okay, that I have not tried.
Yes, sir.
Hmm.
Especially in pediatric patients, sir.
Okay, right. Okay, right. Now, this is only just to the completion's sake. This patient had alternative something history. Look at the involuntary movement. He has got choreic movements about the trunk, sudden jerky movements, and suddenly he shoots up from the sitting position like that, jerky movement like that, makes some altering, grunting sounds. That's movements he makes. If you difficult diagnosis, also the additional clue, he had
Sir,
hypersomnia.
truncal choriodystonia in Eglon 5.
Eglon 5, correct. He has got hypersomnia, laryngeal stridor, and this type of involuntary movement. This kind of a truncal movement, some of them may be jerky, some of them may make a chorea, some of them may make a dystonia, some may be myocamic movements. Various types of movements can be described in Eglon 5. This patient was found to have Eglon 5. Okay, that's all the short case now. Shall I go to the long case now?
Yes, sir.
Okay. This is a story of a 67-year-old female. She is an old case of bilateral osteoarthritis for 4 years. History of radiating pain from hip to bilateral lower limb first started on the right lower limb. Almost the same time, the same complaint started on the left lower limb for the past 3 months. The pain was more on standing and decreased by sitting. For the last 1 month, patient noticed electric current-like paresthesia at the back of both thighs, which is more on lying down, not increased by coughing and sneezing. Patient noticed numbness of both feet for the last 1 month, which is more on the soles. Noticed paresthesia both palms again for the last 1 month. First noticed on the left side, followed by the right side. Along with that, she also noticed difficulty in taking food with the right hand and unable to hold a glass of water. Noticed difficulty in walking in the form of buckling of both knees and fall for the last 1.5 weeks. First noticed the left knee followed by the right knee. Patient also noticed that she needed support of one person to walk about for 1 month. For the last 1.5 weeks, patient wanted 2 persons support for walking. So initially the pain was something like root pain, but subsequently it started up in the upper limb. This is the pain, radiating pain of the hip downward. It is more while standing. Then it progressed for the last 1 month, something like electric current like paresthesia at the back of the both thighs, just more on while lying down. Then she noticed numbness of both feet, followed by paresthesia and numbness of both hands, and difficulty, weakness of the hand, and difficulty in walking with the buckling of the knees and fall for the last 1.5 weeks, and then progressive difficulty in walking, requiring support of 2 persons to walk. So this is the story of the patient. Let us see the findings now. Cranials were all normal. If there is some mild wasting of the small muscles of the hand, you can make it out. And the middle part of the forearm also, you can find mild wasting there. The tone was normal. There is no spasticity. Right deltoid a bit mildly weak. Left was normal. That tepid actually to overcome it is mild weakness. Biceps was normal bilaterally. Triceps also normal bilaterally. Wrist extension was normal bilaterally. Finger extensions were weak on both sides. Finger flexors were also weak. This was also slightly weak. Finger flexor weak more on the right compared to the left side. Flexor pollicis longus was weak on both sides. Abductor pollicis brevis weak bilaterally. Small muscles of palmar and dorsal interosseum were also weak. The interosseum and pancreas was very weak. His performance was positive bilaterally. Palmar interosseum were also weak. Predominantly distal, and the performance was weak bilaterally. Predominantly distal, no incoordination of the limbs. Lower limb tone appears hypotonic or even normal tone. Hip flexion was weak on both sides. More weak to the left compared to the right. Knee extension the right side is also weak, but maybe normal on the right side. Left side definitely weak. That is weak. Hip abduction also weak bilaterally. More weak on the left side than the right side. Adductor was normal. Hip extension is also weak on the left side compared to the right side. Dorsal flexor is weak on both sides, but mild weakness compared to the dorsal muscle, mild weakness. 4+ power is there. Each are also good power. Under is also good. See the degree of hip flexor weakness. You cannot keep it on the flex on the trunk. Bounce down. So the hip flexion was more weak on the right than the left. The reflexes biceps normally elicited. Triceps again just elicitable. Sluggish on the right side. Triceps is absent. Finger flexion was absent. Knee jerk, right side is well elicitable. Knee jerk, left side also elicitable, but less compared to the right side. Checked again. Ankle jerks were absent. Plantar indefinite. Sensation, touch sensation is able to feel throughout normally. She said everything correctly.
ഈ കുത്തി ഞാനിങ്ങനെ മുകളിലോട്ട് വരുമ്പം ഈ അറിയുന്ന വേദന എല്ലായിടത്തും ഒരേപോലെയാണോ വ്യത്യാസം ഉണ്ടോ എന്ന് പറയും. ഒരേപോലെ അറിയാലോ.
But she said numbness on the middle part of the little finger.
ഈ കുത്തുന്നതും ഇതും വ്യത്യാസം ഉണ്ടോ?
Then is in the little finger it is
ചെറിയ
decreased.
വ്യത്യാസം ഇട്ടേക്കണേ.
But it is mild different, but there is a difference. Left side is normal.
കുത്തുന്നതൊക്കെ ഒരേപോലെയാണോ?
That is same.
ഇപ്പോഴോ?
Normal, GP sensitive, vibration normal.
ഇപ്പോഴോ? ഇപ്പോഴോ?
Decreased.
ഇപ്പോഴോ?
Vibration is also present in the lower limb.
ഇതേമാതിരി ഇപ്പോഴേ ശ്രദ്ധിക്കുമ്പോ ഇപ്പൊ എങ്ങനെയാ?
She made mistake on the right little finger.
ഇപ്പോഴേ
Left side normal.
ഇപ്പോഴേ 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 ഇതുമ്പോഴേ ഇവിടെ ഇരിക്കണേ. അപ്പൊ എങ്ങനെയാ? ഇപ്പോഴേ ഇപ്പോഴേ
She said correctly on the left side. He said some numbness in that area.
എവിടെയെങ്കിലും ഉണ്ടോ? ഇപ്പോഴോ? ശരി. ഇപ്പോഴോ ഇപ്പോഴോ മതി.
She had tremendous difficulty in walking, needed 2
അവിടെ
persons to
നിൽക്കുമോ?
walk about.
ഇനി കണ്ണടച്ചേ. വേണേ ഞങ്ങൾ പിടിക്കും.
Thrombus is mildly positive.
കണ്ണടച്ച് നിൽക്കുക. എത്രത്തോളം നിൽക്കേ. വേണേ ഞങ്ങൾ ശരി മതി.
This is how she walked, very cautious, short-stepped gait.
നടക്കേ. മതി മതി.
So I'll show the gait once again. This is when started examining, getting onto the bed now. Before that, this is how she walked.
നടക്ക്.
She had marked hip flexion weakness, more on the right side than on the left side. So on examination, motor wasting of medial forearm and small muscles, tone hypertonia both upper and lower limbs, power in the upper limbs, right deltoid, mild weakness, other proximal muscles, left deltoid, both biceps, triceps, wrist extensions are all normal. Mild weakness of finger extensions, finger flexors, and wrist flexors, and all small muscles of upper limb slightly more weak on the right side. Lower limb, grade 2 power of the hip flexion on the right, grade 3 on the left side. Hip extension and abductors were grade 4 plus. Hip adductors grade 4 on the right side, plus on the right side, 4 on the left side. Almost normal I got. Knee extensions grade 4 bilaterally. Knee extensions were grade 4 bilaterally. Maybe slightly more weak on the right side. Dorsiflexion plantar flexus good power, almost 4 plus to 5. EHLFS is mildly weak. This is regarding the motor power. DTR upper limb both biceps supinator just elicitable. Triceps absent bilaterally, finger flexion absent bilaterally. Lower limb knee jack normal on the right side, 1 plus on the left side. Ankle jack absent, plantar indefinite. So this is reflexes, biceps 1 plus, supinator 1 plus, triceps absent, finger flexion absent. Knee 2 plus on the right side, 1 plus on the left side, ankle absent. Plantar abdominal deafness I did not check. Plantar indefinite. Sensory system, touch normal throughout. Pain, Corey impaired in the right little finger and the medial palm. She said numbness, and she said little bit decrease on the middle part of the hand and little finger. Vibration upper limb normal in both upper and lower limbs. The JP sensation impaired over the right little finger, but not present on the, normally present on the left little finger. Impaired over both toes. Thrombus test is positive, and patients was very cautiously with 1% support. So any clarification you want on the cyst examination, I'll do that.
Sir, can you show the Romberg's test and the gait once again, sir, please?
Yes, sure. Just 1 minute.
ഇപ്പോഴോ അവിടെ നിൽക്കും.
This is Romberg's test.
ഇനി കണ്ണടച്ചേ. വേണേ ഞങ്ങൾ പിടിക്കും.
It is positive.
കണ്ണടച്ച് നിൽക്കുക. എത്രത്തോളം നിൽക്കേ. വേണേ ഞങ്ങൾ.
She has to close her eyes. This is how she is walking.
നടക്കേ. മതി.
This is another gait which is shown.
അത് തട്ടാതെ. നടക്ക്.
Sir, was there some foot drop during the gait, sir? I could not see.
Well, a foot drop was not there.
Sir,
She's not
she could walk on toes, sir.
No. That I did not check because she proximal muscles are so weak that she cannot lift up one leg. Maximum weakness of the hip flexors, knee extensors are the maximum weak. That way, she's not able to lift up, push the leg forward. Dorsiflexion, plantar flexion was really good, 4+ power. With great effort, I can just make a little bit movement of overcome the movement of the dorsiflexion. Practically normal or
Yes.
4+.
Sir, if we go by the history, it is starting like LS radiculopathy, but as the illness progresses, we find that it is predominantly an element type of a weakness, which is having a severe lower limb proximal involvement in the pattern of the L2, L3 or the femoral nerve, affecting the hip flexors and also the hip adductors, the obturator nerve distribution. And in the upper
Adductor was not that affected. It is
Okay,
still
sir.
affected. Maximum abductor was more weak than the adductor.
Okay, sir. So we have to implicate the other roots, the L5. Yeah, and in the upper limbs, it is more of a distal predominant involving all the nerve pattern or extensive from C6 to C8 and also some suggestion of a C8 sensory in the right side, but it may be attributable to previous ulnar nerve neuropathy and in the right side there is also some deltoid weakness, so that also may be attributable to the age of the patient and all these things, so
I
I
think
would not consider.
deltoid weakness, I think we can ignore because only one she just
Yes,
bent
sir.
it down. But all other proximals were normal. So that
Yes,
stands
sir.
out odd. But main involvement in the upper limbs is distal. Wasting
Yes,
was
sir.
distal, weakness of all small muscles were weak. And
Yes.
finger extensions were also definitely weak. That's very definite.
Yes.
Deltoid only with very great force I could overcome. I think
Yes.
that may not be genuine, may be present.
Along with that, the patient is also having some large fiber sensory in the form of profound ataxia and gait instability while walking, which is more of a sensory ataxic foot drop, stomping type of a gait. So, sir, if there is no perceivable distal weakness as per the examination, so I would consider large fiber involvement as well. And considering the age, it may be a paraneoplastic or a proteinemic CIDP, atypical CIDP, or a multiple mononeuropathy type of a picture, sir, affecting the motor fibers and the large fiber sensory, sir.
Okay, perfect. That's a very good localization. Okay, anyone else like to come?
Sir,
Please.
what is the abdomen reflex, sir?
Abdomen reflex, I did not check. She was wearing that complete parda like thing, not the whole thing. Very
Sir,
difficult to
actually,
take it.
patient has knee extension weakness, sir.
She definitely has knee
But
extension weakness,
but
more on the right
reflex
side.
was present.
Correct. Reflex was present on the
So
right side.
there is some myeloradiculopathy, sir. We consider myeloradiculopathy, patchy involvement both in the cervical and also in the around the upper epiconus region, sir.
Upper epiconus region, where do you want to consider upper epiconus? Epiconus mean which segment do you have in mind? L3, L4?
Yes, sir. Or sorry, sir. Or lower dorsal, sir. Lower dorsal.
Lower dorsal, agreed. So there may be lesion there to account for that. But only that part I agree with you. But all other things is got a hypotonia in the lower limb. And there is weakness is proximal, distal part is spared. If it is a
The history also, the pattern also is not like, it's like a non-length dependent pattern, sir.
Yeah, pattern is it's not like a fitting with the typical root involvement, but in a CADP and all, that will not fit in with the root. If you look at the CADP, do you think it's fitting with the root distribution like a disc prolapse? No. They affect generally proximal muscles more than the distal muscles. They don't take the pattern of a radiculopathy due to disc prolapse and like that. So in fact, CADP presentation is nothing but a proximal motor neuropathy. Proximal and distal predominantly proximal motor neuropathy. Those nerves which supply the proximal muscles are more affected, that's all. Because the nerves which affect the proximal muscles are more myelinated, so they get affected first. It does not respect the so-called root. So the term radicular neuropathy is actually misnomer. The weakness in IADP or CA does not fit in with the root pattern at all. Just because proximals are more affected than distal, we coined the term radicular neuropathy. That's in fact a not a correct term to use to diagnose, to localize that thing. But some or other people are in the habit of using radicular neuropathy for an element type of weakness which does not fit in with a nerve root or a nerve involvement, which is affecting more proximal than the distal. They coined the term radicular neuropathy.
Sir, the newer residents now tell neuroradiculopathy to be more accurate, actually.
Actually, we should not bring radiculopathy. How do you know radicals are affected? Everything can be explained by nerve itself. When the pattern is only the distribution of a root, you can call radiculopathy. In AADP, does it fit with the root distribution at all? No.
So the only thing is that in the lower limb, if we analyze the part, the major involvement is in the distribution of the femoral nerve. So if a femoral nerve being not, if you also have a sensory component to it, we might expect some sensory involvement in the course of the femoral nerve as well, or the lateral femoral cutaneous. So we should bring root also, I think, in the lower limb, because some kind of a, yeah.
The thing is that which muscle is in the root distribution? No muscle weakness in the root distribution. If you think a femoral nerve, you can explain the hip flexion, knee extension, but that knee jerk is well excitable and there is no sensory loss in that nerve distribution. Sensory loss is only JPA sensation confined to the distal part only.
So, that's why if you are having a knee-jerk loss, that would suggest more of a neuropathy or a radiculopathy, sir.
Yeah, that's correct. What I'm trying to say is that the term radiculopathy does not mean, in the radicular neuropathy does not mean roots are affected. The muscle weakness are not fitting with the radicular distribution. That's all what I meant.
Okay, sir.
See here, you can say, except for the knee jerk, absence, most of the things are element only. Hypertonia is there, proximal muscle more than the distal weakness.
Absolutely.
Other reflex are absent. So it's an element weakness. That's statement number one. Second, element weakness can be anterior console, root, nerve, muscle, and minor. Here you got a sensory involvement. So we have to think of either radiculopathy, but radiculopathy does not fit with the radiculopathy. Resin with the neuropathy again does not fit in the neuropathy except probably for the ulnar distribution of sensory loss.
Yes, sir.
So yeah, so we call something like a radicular neuropathy as you see in a CADP like pattern. For a proximal and distal motor sensory neuropathy. Or a symmetrical motor sensory neuropathy.
MMCB is also a possibility, sir, considering age.
MMCV, the sensory is there in this patient.
Yeah, sensory, yes, sir. MMCB is ruled out.
So these are the findings. So analyzing. Okay. So any other thoughts from anyone? This is a tricky case. Okay, this is how we proceeded with that. Element weakness, both upper and lower limbs. Motor and sensory in asymmetrical fashion, radicular neuropathy chorimatism. Or is it a diabetic hematrophy with the distal sensory motor peripheral neuropathy, which I think is very unlikely because upper limbs are also significantly affected with distal muscle weakness, which usually don't find peripheral neuropathy due to diabetes. So patient came with these investigations. What investigation I did later on, the question came with this MRI of the lumbar spine because she had some radiating, electric current like pain radiating down the lower limb, she said initially. There is a lumbar spine and lower dorsal spine. This is dorsal axial cut, lower dorsal axial cut and lumbar cut, D2 L1, L1 L2, L2 3, L3 L4, L4 L5, L5 S1. Then the dorsal spine axial and sagittal cut. Again C7 D1, D1 D2, D2 D3, D3 D4, D4 D5, D5 D6, D7 D8, D9 D10, D10 11. Up to L1 it's normal. So, what investigation would you like to do?
The detailed NCS and EMG studies, sir.
Right. This is a blood workup with came. So that's when he admitted my hospital. That investigation
Sir,
done was
what
NCS.
was
Yeah.
the MCH, sir, in the CBC was the was macrocytosis present?
No, this is
No.
the
Okay.
NCS.
Yeah, yeah, yeah. It's normal, sir. Okay, sir.
Okay. So this is NCS done here. Left peroneal amplitude was not be obtained, but it could be picked up from the tibialis anterior. From the EDB, it is not picked up. Left ulnar normal. Right ulnar sensory again. She's completely sensory loss, but it was not there in that electrophysiologically. F5 latency is right median is prolonged, left median is also is prolonged. So I think I'll go back to the NCS once again. Left peroneal EDB is absent, not picked up, but postural pickup was there. Right ulnar ADM normal, left ulnar ADM normal, sensory normal, even the patient said numbness on the medial part of the hand and the palm. F5 latency is prolonged in the median and left median. So relatively normal conduction except for the prolonged F5s in both median nerves and decreased EMAP amplitude from the left peroneal picked up from ED. This is the only finding now. Now,
Sir,
how will
one
you proceed?
clarification from the examination, sir. On fixing the hip joint, was there truncal flexion possible? So the truncal muscle was weak or not?
That I did not look. See, the problem is that when the hip flexion is weak, the trunk,
Yes,
you
sir.
cannot flex the trunk. Got the
Yes.
point? Okay. The flexion of the trunk requires normal hip flexion.
Yes, sir. Yes, sir. Sir, according to the NCS, we cannot we cannot stamp it as a neuropathy because the snaps are absolutely normal. And
Correct.
it is a mode of a proximal, it can be a proximal conduction block because there is FF, gross FF abnormalities across multiple nerves, all of which are implicated. Some of even which are not so much implicated, there also we find FF abnormalities. So a detailed FF chronodispersion and persistent studies followed by a EMG should be needed because it
Right.
looks like more of a radiculopathy than a neuropathy from the
Right.
NCS.
Right. So even radicular neuropathy also, no, if there is a proximal
Yes, sir. Yes.
conduction block, but when NCS may be perfectly normal. Okay. The indirect evidence as is correctly is the prolonged F5 in two nerves. That's indirect evidence that there is a most likely a proximal demyelination is present. Okay. So that goes with something like a proximal demyelination, indirect evidence of a proximal thing. So as you said correctly, chronodispersion things, just like we discussed last time, can be done. So this is the diagnostic possibility: radical neuropathy, probable proximal conduction block, or monoitis multiplex, less likely in view of the relatively normal NCS. So what other tests you need?
EMG.
EMG is not going to help us. We know
So
it's
then FF
significant.
studies, FF studies we are.
If studies can be done, that's correct.
So
But
then CSF.
CSF has been done. So test CSF was done. And ANA profile, best for completion, saying and Pianga. So CSF showed 119 protein, no cells. There is albinocytological dissociation. And ANA profile was negative, saying a Pianga normal. Now, what do you like to do?
So we have to image the MR neuronography
MRI.
protocol with nerve root imaging with contrast and fat suppressed images in the
No.
lumbar and the cervical.
Okay, that is ideally what you said is correct. But practically, she couldn't afford anything more. She's
Okay.
done already an MRI twice. She
Only
said,
contrast.
contrast MRI.
Yes,
Okay,
sir.
right.
Was there any clumping of cords, sir?
Clumping up?
Cord
Roots.
clumping, sir.
No,
Roots.
no, no crumbling at all. That I showed earlier.
Sir, we can do a SPEP, sir, protein electrophoresis.
Why? Because we know there's got elevated albino-cellular dissociation. But the pattern is something like a radical neuropathy. So fit in with what? CADP only.
Yes, sir, but
Sir,
in this
sir, we
stage, we
should
should
go for
consider
a
some
straight. We
secondary
should go
causes.
for.
Pardon?
We
The
should go
secondary
for.
causes.
Secondary cause, of course, can be ruled out. Yeah. Then
Secondary is usually ruled out, and we should actually go for one therapeutic study now, sir. We will
yeah,
straightly.
that's
There is
that's
a
no, that's usually these situations when you find a CDP pattern and elevated protein and no cells. If there is a typicality or something, then we can go for the other investigations.
So
Routine
we can
ALS
do an
propensity.
SSCP. Lower limb SSCP can be done to, because the
No,
snaps are normal.
how are you going? How is it going to help you? Because no, the SSCP, even the normal conduction is there and it's normal. Then SSCP, how can it help you?
Sir, if we are having, because there is profound sensory ataxia, if we are having a
Correct.
CIT, yeah.
Yeah,
So
correct.
we have to do an SSCP because it can be a CISP or a CISMP kind of a picture as well, because it is a subacute history.
Right. That's obviously it is there, no? Since he has got a
Yes,
normal
sir.
sensory conduction, we know the lesion is proximal to the ganglion. That is
Yes.
the root only. Huh?
Yeah, correct.
Yeah, as represent, it's the root only.
The immunofixation.
Immunofixation. Oh, those things can be done. Okay. So practically what you should do would be like situation, put it, I think just
Steroid.
IV
yeah.
methyl prednisone.
Yes, sir. Yes, sir.
Yeah,
Obvious.
we could see if we start investigating, you can start investigating the whole length, like in the textbook given. Practically, what we give, so all sufficient evidence to suspect a CADP like thing, you would put the treatment.
What about LP?
LP was done. LP showed a albino cytological association. Right? That showed you. LP showed 119 protein and no cells.
So the cell count was less than 5, or what was the CSF cytology, sir?
The only no cell is there.
Okay.
Okay. So the patient was given IVMB, weakness improved partially and was able to walk without support. Now she's followed up after 2 weeks. Now let us see the weakness after 2 weeks. It just significant weakness inflection that improved. Initially she was not hold against gravity. Now it has improved. Knee extension also improved. This reflection was as anyway normal previously. The reflex is slightly brisk on both sides now. Let's come back. Angle checks were absent. Upper limb findings remain the same. Upper limb reflex remain as previously only, not much of a change. Triceps continued to be absent. So followed after 2 weeks, a lower limb weakness improved. Knee jerk has become brisker. However, 6 weeks later, a weak walking difficulty worsened. After 6 weeks, weakness worsened again, needed support of 2 persons to walk. Now let us see the percent finding now after 6 weeks. Tone still hypertonic. You can see the wasting of the calf muscle there on that left side. You can see. Deflection was grossly weak compared to the previous state. Right, she could not lift it at all. She could not lift it against gravity. Initially, she was able to do that. Knee flexion, knee extension also became weak. More weak than previous state.
ഇത് നിർത്തിക്ക് 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 നിർത്തിക്കുമ്പോൾ
Left side also is become weak.
ഈ പാദം മുകളിലോട്ട്
Dose selection was weaker than before. Initially it was good power, 4 plus. Now it is only 3 plus power.
അത് പിന്നെയും കൊള്ളാം.
Again, see the right side is more weak than the left
ഇത്
side.
പൊക്കിക്ക് വെള്ളകെട്ടി പൊക്കിക്ക് ഇത് പൊക്ക് മുകളിലോട്ട് പിടിച്ച് മുകളിലോട്ട് പിടിക്കാൻ നോക്കിക്ക് ഇത് വിരൽ മാത്രം മുകളിലോട്ട് പിടിച്ച് ചവിട്ടിക്ക് എൻ്റെ കയ്യിൽ ആഞ്ഞ് ചവിട്ട് ഇത് ചവിട്ടിക്ക് ഇത് കാലകത്തി പിടിക്ക് അകത്തി പിടിച്ചു അകത്തി പിടിച്ച്
Abduction was weak,
സമ്മതിക്കില്ല
more weak than when the previous state.
ചേർത്ത് വെച്ചമ്മ
Abduction also became weak. Now coming to the upper limbs, the reflexes. Biceps is solicitable just like before. Supinator is almost absent. Triceps is absent. Supinator again. Finger flexion was absent. Knee jack has become brisk bilaterally. Ankle jack absent. Then check the sensation. Joint sense normal in the thumb bilaterally.
അതുപോലെ ചെറുപേരില്ലേ
Right little finger is absent, decreased, absent, just like before. The left little finger also it become absent now.
ഇപ്പോഴോ ഇപ്പോഴേ
Initially left little finger she could say the joints normally. Thumb it is normal before and even now. Lower limb is absent just like before.
ഇപ്പോഴോ അറിയത്തില്ല ഇപ്പോഴില്ലല്ലോ
This is how he should walk now. Tremendous difficulty in walking. He tend to buckle, tend to, yeah. Upper findings remain the same. Both reflexes, abductors, adductors, hip, knee extensors, and dorsiflex angle became more weak, mainly knee flexes and dorsiflexes. Weakness is more weak on the right side. Both biceps supinate have become well ill-suitable. Both triceps finger flexion absent. Both knee jack become brisk right more than the left. Both angle absent. Sensory finding same as before, except that the JP sensory loss is there in both little fingers. What is your diagnosis now?
Sir, what was the glycemic status of the patient when she first came?
What
Diabetic.
status?
Sir, the diabetic status, the sugar and the HbA1c.
That is okay, normal, controlled. That is something
Okay.
we need for them.
Sir, if there is such kind of a picture where there is a transient improvement followed by more of a static course or a progressive disease in a case of a CIDP, we should consider underlying myelomatous causes, paraneoplastic causes, and sometimes diabetic CIDP can also worsen after treatment. So if the patient cannot investigate further, we can put her on some long-term steroids considering the diabetic status or some steroid sparing agent, or we might investigate further, sir.
Yeah, you think a typical CADP, okay. So any other,
Repeat NCS, sir.
NCA
Repeat.
should be repeated definitely.
Repeat
Okay,
NCS.
okay. Okay, any other thoughts?
Sir, any family history, sir?
No family history.
Sir, that leg looks like an inverted champagne bottle, sir.
No, these are all acute presentation. No? That is because of the wasting of the cup. Sir,
What was the ESR, sir?
ESR is normal.
CPK?
CPK, I did not do. Sensory was also affected, no?
Sir, nodopathy.
Nodopathy, proximal nodopathy.
Nodopathy, okay. No, I did some other test. I will show you the test and why I did that. I'll tell you later on. Now, where is the lesion now?
The radiculoneuropathy still, yeah.
So it's not a radicular neuropathy, it's a radiculomyelopathy.
Myelopathy.
Because, the reason that somebody has pointed out that point very early, that is, but there are certain odd points at that time. See, even though initially the knee jerk was just plus minus and all, slightly brisk, now the weakness has progressed in the knee extensions, but the reflex has become brisker. That cannot go with the radiculopathy. In fact, even if the brisk reflex that should become absent. Now it has become brisker, right? So what does it tell you? That means reflection is in initial is a UMN type, not element type. Okay, you got the point. Did you see I think so, the video once again? See this is the see the knee check. She hardly can lift up the leg, but jerk have become brisk. How is it possible with the radical neuropathy? Then one more thing I'll let you know if I look at that. So what is the diagnosis now? What test do you like to do?
MRI cervical spine.
Correct. And the reason, and one more thing I'll tell you, I just showed the video, but overtook one finding. Look at this point. Did you see me repeatedly checking the finger flexion jerk here? Usually you do 1 or 6 times. I was checking again and again. Why?
Yes, sir, yes.
Yeah, right. Why did I put that? I wanted to look for that. Now let us see she's got an inverted supinated jerk on the right side. I will show that finding. Look at the same neck patient. Biceps is absent. Look at the fingers, finger flexion movement with the supinated jerk. Did you see that? I'll show you once again. Don't look at the flexion of the supinated contraction. Look at the fingers. See the finger is flexing it. That tell you is got this CA segment is hyperexcitable. But finger flexion reflex is absent. But you got an inverted supinated jerk.
Sir, there was also supinated contraction when there was tapping on the supine.
Very mild contraction. There is very mild, hardly any contraction.
Sir, how to differentiate between that phenomena that you once told in that class to radiation and inversion, sir?
That I'll tell later. Just after completion. Okay. I'll tell that. That's a very interesting question. Why? Logically, when you get a finger flexion reflex, if you're tapping the finger, also should be brisk, no? Here it is absent. But the finger is flexed, only you do the supinated jerk. That explanation I'll tell later on. Now, what you want? MRI cervical spine. Look at what is there in the MRI spine. This is the MRI cervical spine. 4, 5, 6, and 7. Large disc prolapse with something like it's like hyperdensity with pancake, right? Hyperdensity within the cord. There is an intramedullary lesion in the cord due to this, probably secondary to the ischemia, compression, ischemia secondary to the compression. Now, how to explain here proximal muscles to the low volume weakness by this compression? See, when the first
medial pyramidal tract involvement.
No, not medial pyramidal, medial part of the pyramidal tract. Okay. So that means that contains the proximal muscles. So what I'm see even the first examination also, her knee jerk was very elicited on the right, both sides, more on the right side. That is the mistake I did. But everything was something element. That is the only odd point. So now we took this axial cut now. See the degree of compression of the cord. Now, is it a pure cervical spondylometropathy or myelopathy with diabetic hypertrophy? Can you explain the findings cervical spondylometropathy alone? Then this stands a discrimination may be ischemic myelopathy. So what is a mistake I did in the interpretation of findings in the first examination? The muscle which is more weak, that is right quadriceps, had well retained reflexes. That is the point. And weakness of all small muscles, the both upper limbs, with relatively good power of the distal muscles to the lower limb, which is very much against a diabetic peripheral. That's also slightly more favoring in a high cord compression. You get a small muscle wasting and weakness in the hand. This patient did not have any wasting of the distal muscles of the lower limb. So these are the things, two things which I overlooked in the first examination. Because all the things are favoring elements, so the only retained reflexes, I ignored that. See, even any small atypical finding in neurology examination should be important. And moreover, already the MRI was taken already up to that level. At the upper part of the lower part of the cervical region, also MRI she brought with MRI, and the MRI which she brought contained up to that level. So that's a lesson in this patient. So always every finding is to be given to
Snaps
importance.
also was normal, no, sir?
Pardon?
Snap was also
Snap was normal.
normal.
That's another point. See, but only thing is that the only CMAP decrease was on the EDB. That may be TDB and can produce like that. Other motor controls are also normal. Snaps are also normal.
Sir, CSF protein raised and improvement with steroids.
Yeah, sometimes even discompression can improve transiently with steroid. CSF protein elevation can occur with the diabetic as well as with cervical cord. Mild compression also can produce elevation, but even diabetes can produce.
F waves are long, no, sir? F waves.
Pardon?
F waves.
F waves are normal except for the two things, other things were all normal. For the median, it was prolonged. That is difficult to explain with that thing. Only median is prolonged. That means if there is a compression above also, the radiculopathy also can produce that thing. See, even that area. If the cord ischemia is extending down a little bit, FF can also be prolonged. Okay, that is regarding that case. Now, one more point I wanted to mention regarding this case is, this proximal weakness.
Little finger, sir, the little finger joint position since became bilateral, so it suggests
that's the point I wanted. Time and again, people who I've taught in quantum, they know very well. This sign I have been stressing very frequently. Whenever somebody comes to you with bilateral little finger numbness or JPS sensation, it's likely to be high cord compression. And every sensation will be normal. Vibration may be normal, everything normal. Only abnormality early may be joint position sense. This patient complained of numbness of the right little finger and joints in absent in the first examination. Subsequently, cord compression progresses occurred on the left little finger also. That is another clue telling that it is likely to be in the root. Because she has sensory loss, but snap on the ulnar nerve was normal. That can occur with any root involvement, agreed. But only numbness here, that's another important. No other area she complained of numbness. That is also usually seen in high cervical cord compression. These are the 2-3 points which I would like to keep you in mind. Can think you always, if that is there, think of a cervical cord compression. Now, regarding your question of inverted supinated jaw, see, normally when there are classically seen inverted supinated jaw is seen C5, C6 lesion. and there's a pyramidal lesion below at C7 or C8. So when you tap the supinator longus muscle, that's brachioradialis, the afferent input goes through the C5, C6 root or C6 root, reaches spinal cord, and then radiates to the other segments also, lower segments also. Since there is a pyramidal lesion at that level, the segment below, that is C8, C7 or C8, are in a hyperexcitable state, anterior hyperexcitable state. So they get irradiate and become more brisk. That segment is absent because that side is there is an element lesion there. Okay. Suppose there is yeah, that is why it is not present on that area. But for that, afferent should be intact. If you imagine there is a C6 efferent is lost, afferent is intact, then this input can go to the afferent, reach spinal cord, and excite the hyperexcitable neurons below, producing a brisk finger flexion reflex. Got the point? Okay.
Yes, sir.
That is one explanation of inverted supinated check. Suppose, may I ask you then, if afferent is also affected, then how will you get invert? Still you can get inverted supinated check. Suppose imagine the C6 afferent is lost. Then you may ask, how can the impulse reach its cord? Afferent is lost, but still you can get, because when you tap the finger, the supinated longest tendon or stretch the forearm, not only the supinated longus or the brachioradial stretches, the stretch is also transmitted to the other muscles of the form. So the input can some degree of input, the stretching input, the stretch receptors are also stimulated in the other muscles. They go transmitted to the other segments. So they can go and excite the segments below. That is why you can hear whether its afferent is affected or efferent is affected in C6 root. Still you can have a hyperexcitable brisk finger flexion reflex. Okay, that is a pathophysiology of this thing. Now, here the problem is that in that case, you expect the finger flexion to be brisk. Correct?
Yes, sir.
Yeah, if it is only C6 level, why should the finger flexion should be absent? Here, finger flexion is absent, and the same day, fingers are flexing when the supinated jerk is elicited.
So because ischemic myelopathy.
No, not because, no, the explanation. That is because if that is to occur, the efferent of CA-D1 should be intact, the afferent of the CA should be absent. You got the point? If afferent is absent, you will not get finger flexion.
Yes, sir.
But efferent is intact, you get a brisk this thing, because not by finger flexion reflex, by the supinated jerk. Okay. That is why that is what is happening in this patient. This is not a common situation. Commonly, when you get inverted supinator, you get by tapping supinator jerk, fingers flex. Not only that, the finger flexion should be brisk normally.
Yes.
There are situations, sometimes it may not necessarily be brisk. Okay.
Sometimes, sir, when you're tapping the supinator longus, you may get a brisk biceps jerk also. Why that happens? Because of a myelopathy?
No, if a bicep jerk has to occur, the lesion has to be above the C5. In that case, we should not call it as an inverted supinated jerk. To call inverted supinated jerk, the brachioradial supination should be decreased or normal or decreased, and the finger flexion should be brisk. The biceps also is brisk, then it loses its value.
What was the explanation you said about the absent finger flexion and
the explanation is so for the finger flexion, normally if we are tapping the finger flexors, the afferent is still going through the C8 segment, goes to the C8 root and go to the spinal cord and comes out through the C8 root. That is how the normal finger flexion is. Imagine the afferent of the C8 is lost. Then you will not get afferent is lost. Efferent is lost also. You will not get the finger flexion. Both can result in loss of finger flexion. Imagine the afferent from the C8 is lost, but the efferent is intact. Then what will happen mean, if you do the finger flexion classical way, it will not get it. But the efferent is intact, the antagonal cells are intact for the C8 segment. So if there is irradiate impulse from the upper segment, that can stimulate the hyperexcitable C8 antagonal cell. Reflexive it cannot stimulate because the afferent is not there. But since the impulses coming from the C6 root can radiate down and stimulate the hyperexcitable C8 antagonal cells. So if the afferent of C8 is lost, efferent is intact, then you can have this kind of a brisk finger pressure on tapping the supinated check, but direct finger pressure stimulation, you will not get it.
Sir, in case of mononeuropathies like CTS and distal muscles or arm muscle weakness, can we also have a decreased finger flexor? Because in this patient, sir, we are having gross weakness of the finger muscles, and there is also some degree of finger flexor weakness as well. So, sir, can it be attributed to that?
No,
The
not
loss
at
of
all.
the
No. See, here the finger flexor is a good power. Only for small muscles are affected maximum in this patient. Finger flexor only very mild weakness.
Okay, sir.
Okay, shall I go to the next case?
Yes.
Yeah, time for one more case. This case is given by Dr. Divya, who works with me. This is a story of a 60-year-old hypertensive lady. Her complaint started 2 days back. While she was standing in the kitchen, she noticed numbness, not paresthesia, she has a heaviness of along with weakness of the right lobe. She sat down and required the help to get up from work. Since that time, she noticed that she is dragging her right foot. So something like a stroke presentation. She came on the second day, examined, upper limbs are all normal, so I'm showing only the lower limb finding. Lower limb, both proximus are normal, knee extensions are normal. Her complaint was on the right side. Dorsiflexion also relatively normal bilaterally. But EHL was weak on the right side, normal on the left side. Flexor hallucis longus was normal on the left side, weak on the right side. So EHL and flexor both were weak on the right side. Evasion was also weak on the right. See? So I can easily overcome, not on the left side. Triple H bilaterally brisk. Expect right only brisk, but bilaterally brisk. Angle checks were normally elicited. Plantar indefinite. Sensations were all normal. There is equal on both sides, she said. Vibration also said normally elicited. Joint sense also is normal. She said correctly. Again, she said correctly. You couldn't hear the answer, she said correctly. There is no graphesthesia. This is how she walked. She's dragging the right leg. You can see the dragging of the right leg. Okay. Tone normal in both the lower limbs, but actually spasticity is there while walking. Power, weakness, inverters, EHL, FPL on all grade 4 plus. Detailed both knee checks plus, angle check 1 plus, plantar indefinite, sensory normal, SLR negative, spasticity to the right lower. So these are the findings. So what is your diagnosis?
Sir, it looks like an UMN kind of a weakness of the right lower limb.
Right.
So, in a hypertensive lady with more or less acute onset of illness, so we have to suspect some vascular etiology first, and weakness is also suggestive of a distal predominant, more of a dexterous kind of
Yes.
a weakness of the AHL and the FPL, and that is definite evidence of spasticity. So, upper cervical cord or the brainstem stroke, or sir, we have to check for the cranial nerves as well.
They are normal. They're all normal.
ACA territory stroke, sir.
Yeah. The first thing you have to keep
ACA.
is ACA territory stroke. It's a light lowerly monoparesis. No, ACA territory stroke is the one you have to keep in mind. Okay. So that's the first thing you have to keep in mind. Okay, right. Because that's a situation where you don't have any other things. Brainstem, you expect some other finding. Upper cord also you expect some. Cervical cord also you expect something else. So the MRI brain done 24 hours later. This is the MRI. There is no infarct seen. So what it did, repeated the MRI. Sometimes, acute infarct, sometimes may be picked up, it might be picked up in the diffuse initially. So I repeated the MRI 24 hours later. I asked for a typical coronal cut. Sometimes it may be picked up only in coronal, small infarct may be picked only in coronal cut. That is a parasagittal area. Again, no infarct seen. Now, where are you now?
The angio was also normal.
Angio, I think must have been normal. I don't know. The stroke protocol we did must have been done. I did not
So
show the
upper cervical cord MRI and cervical
No,
dorsal.
third MRI after 72 hours, sir.
Okay. Third MRI can be done. But actually 48 hours it should be 72 hours brainstem stroke. Of course, we can do that someday later. Semispherical, actually 48 hours it should be seen.
So some evidence of uppercuts in the uppercuts, there is some hemosiderin latent.
No, nothing.
Another location possibly is on pons, because pons
Yeah.
also the fibers are wide apart.
Yes, so brainstem we have to see
You have
also.
to take a thin cuts at a pondine level.
Pondine level, okay. So the pons is actually taken in twice. It was normal because coronal cut also pons. I did not show the picture. That is normal. So in fact, I screened the spine, cervical cord, and the cervical, the dorsal cord. This is the dorsal cord axial cut. It is more than cervical. Dorsal cord is more important because patients no complaints in the upper limb, but only in the lower limb is there. So dorsal cord is the acute presentation. No, it's more likely that. So MRI dorsal spine normal.
The contrast was.
No, contrast to acute presentation. What I think. Okay, of course, you can think of something else, but there is nothing seen there to find a contrast. Now,
Diffusion weight MRI of the spinal cord. Diffusion weight MRI.
Right, very good. So I had to take thin cuts at the D4 level, and they were I can explain that. So let us see the thin cut now. See the cord, I'll show them a little more better. See the hyperdensity within the cord. Can you see the arrow pointing to that?
Yes, sir.
Yeah. There again, you can find the hyperdensity. It's a poor quality, but not because the grainy picture. You can find out the hyperdensity there also. And this is the contrast. Hyperdensity there. I will show the diffusion films also. And this is the diffusion. It's difficult to comment on diffusion films and spinal cord, but still you can make out the hyperdensity on the right side, same side as the weakness of the lower limb. You can find the hyperdensity there. So seeing that, I re-examined the patient to find out any sensory level or anything in the abdomen. So I checked re-examined she never had a sensory feeling initially. I checked the abdominal reflex, I checked the pain sensation to find out any sensory level at that level. There was no sensory level, No sensory findings in the
ഇല്ല
trunk.
ഒരേപോലെയാണ് ഈ ഞാൻ വരയ്ക്കുന്നതും ഇത് ഒരേപോലെ
She said both are same, no difference.
ഒന്നേ തന്നെ
And touch sensation also checked. It was not there. So what is it? So most likely infarct in the dorsal cord. Now, what else you need now?
Sir, in the spine, was there any break in the pulposus area suggestive of nucleus pulposus embolism? Because the cord appears to
no,
be
no, there's
somewhat
not.
anterior. Okay, okay.
No, nothing. There's no disc is entirely normal. Entirely normal. Usually in nucleus pulposus embolism, there's some backache or some, it will be, a disc backache will be there. Because it actually, the disc protrude into the bone marrow or the vertebral body. So initially put is some pain. That may be even one day before. That history was not there in this patient. And the MRI was also not showing any disc lesions.
Vertebral artery, vertebral body infarct. No.
Yeah, look for, yeah, exactly. Very good. That is what you look for. So look for the vertebral body infarct. There is no vertebral body infarct. What else you want now?
And to rule out any vertebral dissection or vertebral artery dissection or
This is the thoracic cord, no?
spinal artery and spinal artery.
Okay, dissection the spinal artery. What is it?
Aorta.
Aorta or vertebral artery.
Correct. So
Adam
this is
Curious, Adam
correct,
Curious.
but since it is usually if it is cervical, you should look for a vertebral artery perfectly, as you said. Since it's the dorsal cord, you look for the descending aorta. Now let us see. Do you find anything abnormal here?
Yes, sir. There is a double intimal flap sign.
Right. There is a hematoma there in the aortic wall. There's aortic dissection. And that caused the ischemia to the radicular artery and produces a small infarct in the sulcocommissural artery. Should I quit here?
Pain. No pain. No pain.
No pain. No pain. In fact, there is some calcification of the aortic wall, and this is the hematoma. Usually expect pain, but shows no complaint of pain.
The
What
patient
was
had
the age
numbness,
of the
but no
patient?
sensory signs. Patient was complaining of
No,
numbness.
No, she complains not actually not numbness. She said heavy numbness may not be true numbness at all. Even heaviness also they will say numbness. That's a very common problem in Malayalam language. But she did not any sensory finding. Absolutely no sensory finding. That I clarified. Was it like a paresthesia? She said no. Numb feeling or heavy feeling. Probably the stiffness, she may be referring to that.
Sir, this sulcocommissural artery supplies only the pyramidal tract, or is it supplying any other tract like the spinothalamic?
I think sometime back I showed the various patterns of ischemic myelopathy involvement. And the sulcocommissural artery, classically, if it's involved, supplies the ipsilateral pyramidal and the ipsilateral spinothalamic tract. That means it will produce loss of pain and temperature on the opposite side and pyramidal lesion on the same side. That is what we expect in a sulcocommissural artery, because it comes under and especially on the medial part of the spinothalamic tract. Distal part may be spared. That means the leg area, sacral area can be sometimes spared. That is a classical distribution of sulcocommissural artery. Why the leg area and distal part is spared is because the peripheralmost part, that of the lateral funiculus, is supplied from the periphery, the circulus arteriosus, which surrounds the spinal cord. So it is in fact, sulcocommissural artery goes like that, the peripheral artery comes like that, there's a watershed zone. So when it is affected, if it is cervical cord, upper limb will be affected most. In the dorsal cord, it may be only lower limb will be affected. Only that is there. So that is the medial part of the pyramidal tract is affected in by sulcocommissural artery. Sometimes the entire pyramidal tract may be affected depending upon how far the collateral, the blood flow from the circulus artery is coming, how far the blood is coming in the sulcocommercial artery is coming. In the sulcocommercial artery, someday it may be only confined to the anterior horn cells without any perimeral tract. Can affect the perimeral tract alone, can affect the whole thing, can be affected. Even it can even supply to the dorsal horn also. Because of the territory, they can high variable territory variability in the territory. Just like cerebral circulation, the one area supplied depends upon how far the other contributing collateral channels are coming. So it's highly variable. It's usually pyramidal and spinothalamic. Sometimes it may be only pyramidal, sometimes only anterior.
The disproportionate weakness of the big toe, is it due to the anterior horn cell involvement?
That we cannot take because the maximum affected weakness in the pyramidal tract is the distal muscles. So it can explain that way also. She has got a spasticity in the lower limb and weakness is only that area is maximally affected. That's all we can say. Because that is not an element finding. That's a part of a element finding. Okay. Shall I stop? Or you want more short case?
Or one more case.
One more short case.
One more ultra short case. Okay, this to highlight same. This 45-year-old lady has presented with severe pain in the left shoulder and chest, which radiated to the left upper limb while taking bath. Along with this, she felt buckling of her both legs and she fell down. She was taken to the hospital where she was found to have weakness of both upper and lower limbs within few hours, but was able to move against gravity. By next day morning, she was found to be totally unable to move her both upper and lower limbs. She became quadriplegic within 24 hours time. She also noticed numbness of her both upper and lower limb and developed retention of urine catheterized. Okay, typical some history of a transverse myelitis. Okay, now let us see the findings now. She has got deltoid is weak, but not much weak. She's about 3 is there. Flexion extender was also about 2, not against gravity, but again avoiding gravity, she could move that thing. But we had 1 power of the distal muscles. That distal muscles has 0 power. The lower limb is also grade 1 power. She barely moved. She could move a little bit, rotate the leg like that. This one. Zero distal muscles are more affected. Then reflexes, all reflexes were absent. Finger flesh was absent. Both knee and ankle jacks were also absent. Plantar was subgoing. It was subgoing. I'll check again. So you can see its tendency to go up. Yeah, it's subgoing. I checked again on the right side. That also actually, initially I did not get, now I got subgoing plantar. This was normal. She said yes. Joint sense also check the joint sense. Up, down. On the below. Say down or up? No, down. Okay, good. Abhi? Down. Now? Now? Up. She said correctly in both upper limbs. Down. Now? Up. Now? Up. The lower limb also she said correctly. Here? Down. Be here? Down. Now? Up. Okay. So what is the diagnosis? On examining motor tone, hypotonia, upper limb shoulder abduction grade 3, elbow flexion extension grade 2, wrist muscles grade 1, lower limb all muscles about grade 1, DTR all absent, and sensory vibration joint sense normal upper and lower limbs. So what is the diagnosis in this patient?
Anti-spinal artery.
Okay. Why? What is evidence of anti-spinal artery? All reflexes are absent.
That
So
may be due to
in stage of
ischemia of the
shock,
anterior cell.
It is
stage
not
of
the
shock.
spine. No, it cannot be. Spinal shock means complete absence of motor sensory reflexes. Here, sensations are intact. There is no still elevation got a gate to power the upper limb.
Because of the extensive anterior cell involvement.
Right, exactly. So this point, sometime back I presented a case. Then I told you, no, sometimes can be extensive from top to bottom. So what he was telling is entirely correct. See the next video. What examination will you do? I purposely hid one examination. What?
Cranial
Cranial nerves, only spinal cord. Cranials are all normal. Examine.
neck muscle weakness, sir.
No. To call that it's an antispinal artery, what I should do?
Pain sensation, sir.
Yeah, correct. That
Sir, but it is was mentioned that all the sensations were normal, including vibration. So I thought,
no,
sir,
no. See what I have written. Since it's vibration, Genesis is normal. I purposely did not mention
yes, sir,
that.
yes, sir. There was dissociated sensory loss must be tested in this patient.
Right. So I'll show that this thing. Pain? No pain. You're not able to feel pain? No. No pain. No. She will tell when the pain she feels the pain. Tell me when you feel the pain. There she is able to feel the pain. That's the level of the involvement. So it's got a dissociated anesthesia. That means oyster column intact, pain sensitive, the typical antispinal territory involvement, pyramidal, and the odd point is that reflexes are absent. Now this is the thing. See the hypertension extending all along the antispinal artery. I mean the anterior console. The least is the pain in the shoulder region only, but the hyperintensity extends down. This also I told you because the most vulnerability for the ischemia is the anterior horn cells. See, each level you can find the hyperintensity in the axial cut. Again, in the dorsal cord also you can find the hyperintensity here. You can see the anterior part, something in all eye appearance you can see there. Even see the D10 level, there's hyperintensity in the cord. I think I showed that. There is a typical all eye was there. I don't know where it is gone. Okay. So that is the without spinal shock. In fact, landed through the spinal cord, this occurs only in one spinal cord, but the second level cannot cause extensive reflexia. Shows extensive hyperintensity confined to the anterior console over many segments below, even up to the lumbar cord, produce so-called snake eye appearance.
What's the cause of this, sir?
What is the cause in this patient? I do not know. With this case also, I went to Bangalore to take class. They did an iotagram that was normal. Why it occurred, I don't know.
So this antispinal artery is reinforced by radicular arteries at many levels.
Yes, yes.
So why this upper single level or say occlusion at a higher level produce so much of extensive infarction?
Why? This is not, in fact, this is infarction is not the entire cord at all. This hyperintensity is seen only in the anterior console. Because actually what happened means there is a transient ischemia, and the antispasmodic is supplying all throughout. There is a transient ischemia along the length of the cord. But other things are replenished by the radicular artery. Even the transient ischemic change can produce hyperintensity within the anticonsole. See, this anticonsole hyperintensity, after 3 days, reflexes will come back. I'll show you another case next week, where initially all reflexes are absent. Second day, few reflexes. Third day, every reflexes come back. Only the initial phase reflex will occur.
Sir, and this progression over first 24 hours, what is the explanation?
In a development or in the
Yes,
ischemia.
evolution, the patient had minimal symptoms initially, then he developed other substances.
That is classical of any infarct can need not necessarily be abrupt. It can evolve over just like any infarct of the cerebral also, it can progress over the period of time. For example, cerebral infarct for 72 hours, even vertebral basicity can even up to 1 week can progress. That is possible.
So the previous patient, what treatment was given for the patient with aortic aneurysm and thrombus?
I do not know. I don't know. This case is an old case. In fact, I sent her for surgical consultation. I don't remember. I don't remember what treatment was given. He was sent to the thoracic surgeon. I don't know. He did something. I don't.
Anticoagulation is indicated, sir. Anticoagulation.
Anticoagulation, it's no need for them. It's actually dissection occurring, If you give anticoagulation, it will only worsen the dissection. Anticoagulation is contraindicated in this aortic dissection.
Sir, what was the exact level of the diffusion restriction in the cord?
Area of involvement.
Yes, sir. What was the area of
then on the right side of the cord, right half of the cord,
Sir,
there is a restriction.
So the longitudinal extent was from which part, sir? In the actual.
No, it's very difficult to find out that thing. There is some hyperintensity over 2-3 segments. That's all I could make out. It is not a long
So there was some mention in your book in certain spinal shock about this Schiff-Sherrington phenomena, which causes that extensive involvement with very minimal radiological evidence of a spinal cord infarction. Sometimes in acute presentation, we might get very minimal radiological evidence, but very severe clinical presentation.
Yeah, that's also well known. Suppose you get a total areflexia, MRI may be normal, cord may be normal. There is a functional deficit that recovers fast. That is well known.
So
if you happen to see hyperintensity, it's well and good. That proves your point. Okay. So shall we close?
Okay, thank you, sir. Good night.
Okay, thank you.
Thank you, sir.
Right, thank you. Good night. We will meet next week.
Good night, sir.
Thank you.
Good night.
Good night. Good night. Thank you.